an extremely exciting disorder, particularly for an orthopod like myself, because I keep hoping some of those changes are going to put me out of business, which would be wonderful for the kids. So it is with huge delight that I welcome Dr. Michael Bober, who is director of the Skeletal Dysplasia Program at the DuPont Institute, to speak to you today. Welcome, Michael.
Thank you, Laura. Thank you, Michael. Thank you, everyone, for the invitation to talk about one of my favorite topics too, which is taking care of children and adults with achondroplasia. So let's get to it. So some disclosures. I just wanted to please ask everyone to be respectful of these patient photos, because I would prefer for them not to be distributed through the internet. As you all probably know, skeletal dysplasias are a heterogeneous group of disorders that are caused by abnormalities in the growth, development, and maintenance of bone and cartilage. And here you see a panel of 5 kids with various skeletal dysplasias. And achondroplasia is the most common of these conditions. We estimate this to be about 1 in every 25,000 children that are born. And while individually a lot of the dysplasias are rare, taken together, you can see that skeletal dysplasias are quite common, occurring on a frequency equivalent to cystic fibrosis. So sort of to begin our achondroplasia story, we can go to this physician, Dr. Jules Perot, I suppose is the correct way to say it, who was a French pediatrician, most known for his work in syphilis and syphilitic changes in the skeleton. But in 1878, he described an individual with short-limb dwarfism. It's actually not clear whether or not that patient had achondroplasia or not, but he did call them achondroplasia. He coined that term, and ever since, for about 100 years, anybody that had a short-limb dysplasia was in fact termed achondroplasia. Like I said, it's the most common dysplasia. It's characterized by a short-limbed form of dwarfism with rhizomelic shortening, so shortening of the root segment, that is the humerus and femur, are more foreshortened than the other long bones. People with achondroplasia have typical intelligence. This is a dominant disorder. It's 100% penetrant. About 80% of cases are de novo, and there is a gonadal mosaic recurrence risk for achondroplasia. And it's caused by mutations in FGFR3. And as you can see from this picture, which is quite old, achondroplasia has been described and around for quite some time, recognized for a long time. It's caused by mutations in the fibroblast growth factor receptor number 3. And this is a transmembrane receptor in a fibroblast growth factor signaling pathway. This pathway functions as a negative regulator of chondrocyte proliferation and differentiation inside the growth plate. And it is the gene responsible, FGFR3, for multiple skeletal dysplasias, including achondroplasia. It is responsible for a family of dysplasias. And what happens in the growth plate, you remember our proliferative and hypertrophic zones. These zones have chondrocytes that begin to differentiate, proliferate, and hypertrophy. And FGF signaling through the FGFR3 pathway is very important to maintain the balance of the cells as they move through these zones. In addition to being expressed in the growth plate, there's also expression in the CNS in the brain. FGF signaling can be important very early in branching morphogenesis in the lung, and to a much lesser extent in the intestine and in the kidney. And what you see here is the typical way through which this pathway signals. This is a cartoon of two FGF molecules, in this case FGFR3, which in the presence of a fibroblast growth factor dimerizes tyrosine kinase intracellular domains, then phosphorylate downstream proteins, which ultimately lead to gene transcription. The achondroplasia mutation, G380R, so a glycine arginine substitution at position 380, occurs in the transmembrane region of this molecule. Here you see some mutations responsible for other forms of FGFR3 family dysplasia. Thanatophoric dysplasia is TD, HYP is hypochondroplasia. And what happens here is the mutations lead to a biologic phenotype where this receptor signals inappropriately, where this signaling can be both ligand dependent and ligand independent. But we get dimerization. Somehow this G380R promotes signaling through and keeps these FGFR3 proteins in prolonged contact and in a prolonged signaling pathway. In achondroplasia specifically, certain in vitro studies have suggested that this mutation can lead to a constitutive activation of this sequence at about 80% of its maximal signaling capacity. And with that in mind, it's kind of straightforward to think about a spectrum where when the signaling is closer to 100%, we get more significant and more severe phenotypes. The moderate phenotype in this group is actually achondroplasia, and the milder one would be hypochondroplasia. So when we look at an infant with achondroplasia, there's a couple important things to notice. Number one is going to be rhizomelia, which is, as I said, shortening of the proximal segments of the extremities. There's going to be relative macrocephaly, perhaps absolute, but certainly relative, with the frontal bossing of flattened midfacial structures. Here you can see the so-called trident hand configuration. Sometimes it's more of a starfish configuration, but this is seen in infancy in most children. This baby's in a little bit of a curled position, but I think you can get the idea here that this child is going to have some difficulty getting his hands into his pockets. And this is what I like to call the pocket test. And I feel like a good, reliable bedside test to get an idea about whether or not somebody might have a skeletal dysplasia. Is very simply just put their arms down to their sides and see where they fall. Their hands should be falling at about the proximal 1/3 of the proximal femur. If somebody's hands are touching their knees, this is somebody who's going to have a short trunk dysplasia. And if somebody's hands are above the belt line, you know they have a short limb dysplasia. If you have a suspicion, I think that a child does have achondroplasia radiographically to confirm that. This is really the one image that you need. You do not need a whole skeletal survey because this is going to be pathognomonic in a number of ways. As you go cranial to caudal through the lumbar spine, you can see that the distance between the pedicles, the interpedicular distance, narrows rather than widen. You can see the sciatic notches are narrow and very U-shaped. There's flattened acetabula. And there is this very distinct metaphyseal dysplasia at the proximal femur. I like to refer to this as an ice cream scooper. To me, this looks like the kind of a scooper you would use to take ice cream and put it into a cone. So this collection of features, not any one of them, but all of them together, that is really pathognomonic for achondroplasia. So that combination of features, we should be able as physicians to recognize and make a clinical diagnosis straight away. We don't consider short limbs really a major medical problem. They're certainly there. It is a prominent feature, but the major medical problems that exist in achondroplasia really are the result of abnormal growth in the base of the skull. And it's the skull base that leads to the medical issues because of differential growth, slow growth plate expansion, and premature closure. One of the most common things that we see is some form of otitis media, whether it be serous or infectious. The eustachian tubes have a slightly different course through the skull base where they're more oblique than typical. Obstructive apnea can be seen. This is an issue where the front part of the skull base is hypoplastic. There can be a high arch palate. The nasal passages are smaller. Combine that with various soft tissues like tonsils and adenoids, and we have really a lifelong concern for the development of obstructive apnea. Perhaps the most important concern, at least in an infant, is critical foramen magnum stenosis. So that is stenosis of the foramen magnum to the point that it compresses the brainstem and cord structures and can lead to sudden death. Hydrocephalus is another concern. This is usually related to jugular foraminal stenosis and intracranial hypertension. And lastly, things that Dr. Tosi is also worried about: spinal stenosis. And spinal stenosis can occur at multi-levels. Some of them are related to the pedicles being narrowed as well as shortened, creating a spinal tunnel that has decreased volume. And some of it is related to this type of thoracolumbar kyphosis that can become a fixed deformity. And we also see genu vera, the development of bowed legs. These are the major medical issues that are of concern. And I would guide people to this health supervision for people with achondroplasia. Dr. Hooverfong, Dr. Scott, and Dr. Jones, in combination with the AAP Committee on Genetics. This is relatively recent. It's been updated, and it gives an idea for people, excuse me, to on how to surveil and manage some of these particular concerns. Now, switching gears a little bit, I think we've all known this list of medical problems. We've had health supervision guidelines for 20 years, but there's a lot of information that we really didn't know about when it came to the precise frequency or age or things like that. So under the guidance of Dr. Hoover Fong, we and others joined forces to create what we call Clarity, which is a not so straightforward acronym for Achondroplasia Natural History Study. And this is a multi-centered retrospective and prospective registry of patients with achondroplasia that came from these 4 centers: Hopkins, Wisconsin, UT at Houston, and our center. And we collected over 1,300 patients to study these various medical concerns. This was supported in part by Biomarker. Here you can see to date, we've published 5 papers, and there are more that we're working on right now. But I want to go through these individual areas and talk about frequencies and different types of interventions and how those interventions may have changed over the years relative to what those major medical problems are. So here you can see our list of patients here. We had 1,374 patients that were collected. Patients as old as 79 and as young as newborns. One of the things that I found very interesting when you look at this, I'm going to direct you to this red circle, which is the number of children that were diagnosed over the age of 1 month, because we just spoke about how to make a diagnosis. I think to an experienced observer, you should really be able to walk into a room, order an X-ray, and within an hour have a diagnosis confirmed. But yet 20% of our children are diagnosed after a month of age. So you can think about how many care providers that child would have seen relative to labor and delivery and the newborn nursery and the pediatrician and other people. I think this is really unacceptable, and it's also something that hasn't changed. This percent of 20% here has gone on for 5 decades. What's very interesting is people born in the 70s and beyond, nobody was diagnosed prenatally. And now we're up to 1/3 of our cases being diagnosed prenatally. And that's a combination of various types of genetic testing and 3rd trimester ultrasounds. But yet at the same time, we really haven't made any inroads in making a diagnosis. And I think this really speaks to something that needs to improve, and delayed care can lead to bad outcomes. So one of our major issues or major things to study was how it was of surgeries in this group. So what we saw is that essentially 80% of our participants had at least 1 surgery in their life. The average age was about 5 years, 9 months. The median age was 2 years. And if you had a surgery, you are actually probably going to have somewhere around 4 in your lifetime. Focusing now just on the ENT procedures. So these problems, again, are going to be our otitis medias. They're going to be our obstructive apneas. And you can see here that this was, in fact, the most common surgical procedure or surgical category. We divided these categories up sort of by which surgeon would perform them. So ENT surgeries, here you can see 65% of people had at least 1 ENT procedure. What were they? Well, we divided them further into PE tubes, tympanostomy tubes. And here you can see that 56% or 779 individuals had at least one set of tubes. And the mean age for that procedure was right around 3. And here you can see 24% had just one set, 14% had 2 sets, and 10% of the population had more than 3 sets of tubes. When you looked at pharyngeal procedures, which would be tonsillectomy, adenoidectomy, or the combination of both procedures, we saw that 45% of children with a mean age of basically 4 had at least one procedure, and here was the distribution. Drilling down into this data a little bit further, what we saw was individuals who had an adenoidectomy by themselves alone were almost 3-fold more likely to require a second ENT surgery as opposed to those who had an adenotonsillectomy first. So this data suggests that if you have a child who has obstructive apnea and is headed to the ENT surgeon trying to do an adenotonsillectomy would be preferable to just an adenoidectomy, as it seems to be decrease the likelihood of needing a second procedure. The other thing, and all of this is in our ENT paper, the other thing that is published here is this is a look at the frequency of having ear tubes placed based upon the birth decade. And what this is showing us is here's our black overall level, but clearly as time has gone on, we're using tubes more frequently and more often, and at slightly younger ages as time goes on. And I think that's kind of more a reflection of overall medical trends than anything else. Hydrocephalus. You can see the numbers for hydrocephalus are, well, the numbers for brain surgery are around 10% of individuals. 137 people had 326 surgeries. This paper is still being written, so I don't have as much detailed information as the others, but you can see that the vast majority of these procedures were either shunts or shunt revisions. And there are a small number of people, 7%, that went endoscopic third ventriculostomy procedures, which is a procedure that we don't usually think of as one for communicating hydrocephalus. But nevertheless, that appeared to have been effective in a small number of patients. Foramen magnum stenosis. This total surgical frequency was up around 20%, 20.5%. And this is really, really important. If there's one set of facts here to take home is what's the best way to approach this foramen magnum issue. And why? Well, it is now well established that compression at the level of the foramen magnum, compression at the cords of the cord at the foramen magnum level interferes with the respiratory control centers and can lead to sudden death. Typically, this is something that occurs in sleep, perhaps due to neck flexion. We've seen this in car seats and strollers. It can be related to blood gas levels and blood vessel dilation and constriction. And And a few younger children have had recurrent awake apneic episodes, which can be prolonged and sometimes even misdiagnosed as a seizure and this is where that early diagnosis comes in, because if we have a 3-week-old infant, let's say, who has an event like this, and they end up in the emergency room, putting an EEG lead on them, it could potentially be a big miss of a totally correctable problem. Here are a couple of other papers which describe this and talk about how apnea, central apnea, can be the only presenting feature. This is a picture that I think many of us who talk about achondroplasia have in our slides. We have no idea where it came from. So if anybody knows where this picture came from, I would love to know. But you can see the difference in the size and shape of the foramen magnum on the skull, the achondroplastic skull on the right, as compared to the typical skull on the left. So when we're looking at children, what are some of the signs and symptoms that we can see with foramen magnum stenosis critical? That would be gross motor delays. We would be looking for abnormal neurologic examination, especially certain types of long track signs like clonus and hyperreflexia. Most infants with hypotonia, with achondroplasia, have hypotonia, so that in and of itself doesn't necessarily raise a concern, but hypotonia with weakness certainly does. And of course, the central apnea. So gross motor delays in achondroplasia are very specific to achondroplasia. And fortunately, there are a couple of tools, this being one of them, that can aid us in our assessment. So here you can see this is laid out in a similar structure, a similar pattern to the Denver test, where 25% of children achieved the milestone by the leading edge, 90% by the trailing edge, and 50 to 75% in the black range. So you can imagine if you have a child who has a relatively large head and a short neck, that they're going to obtain their head control at a later age, at an older age, as compared to a typical child. We are not going to put them prone on a table at 6 weeks of age and expect them to get their head up at 45 degrees. Not going to happen. And that's not a delay. Here you can see most children achieve head control somewhere between 4 and 7 months. It's a very typical pattern that we see for children with achondroplasia to actually roll over before they develop head control. And here you can see some of the other milestones going all the way out to walking independently, which 25% of children do by 15 months, but the majority are here between 17 and 20. Just for the thoroughness here, language, social, and fine motor development are as expected for any other infant, but gross motor differences are expected. So
she's cute.
And that's exactly why I used her picture, because isn't this the cutest picture of all time? But you know what? It's really not cute, because this child from birth only held her head in this position. And everybody thought it was cute. Physical therapists thought she had torticollis, until she almost died twice with these types of sudden death episodes that I previously described. This child had critical foramen magnum stenosis, And by keeping her head locked in this position, she actually created more space for her cord because of not instability, but physiologic movement, you know, a millimeter or two of movement. She found the widest diameter for her cord to be happy. And I actually saw her this week. She is 5 years now after this horrible weekend, and she's thriving. But this child could very easily be dead because of central apnea and people missing this sign. So her parents gave us permission to use this picture, and it's exactly the point. So if you see this baby come in who's got this really cute head twist, be very careful, because that twist may be a huge clue to something untowards. So torticollis and achondroplasia for me is a reason to do an MRI without any hesitation. But we're going to do standard exams. We're going to do deep tendon reflexes. We want to look for symmetry. We want to look for crossing over of the reflexes, clonus, Babinski sign. Look very carefully for strength and movement. Now, if you go back and you look at Dr. Hoover-Fong's and the AAP's guidelines, they recommend sort of a swaddled MRI for every child at diagnosis. And that may very well be the right thing to do for some centers and for some physicians, but that is not our approach at our center. We really try and base our imaging on people if we can identify abnormal signs and symptoms. So we do sleep studies, we do polysomnography on every baby at diagnosis. That is also in that guideline. But we don't really do the swaddles because we don't really think that that imaging is adequate to make assessments. And one of the other things that we know happens in achondroplasia is here's the same individual about 18 months apart. There's some foramen magnum stenosis here, and it is improved over time. So what happens, broadly speaking, is the foramen magnum grows faster than the cord. However, there can be premature fusion of the synchondroses, and therefore the foramen magnum will stop growing and the cord therefore grows faster and kids get into problems. So it kind of goes both ways. So the serial examinations, an MRI that looked okay on the first day of life does not mean that child is out of risk. And I'll show you in a second that the risk sort of ends right around 3-ish years of age. What do we do when we image? Well, we get our brain with a cervical spine. We are very big believers in flexion and extension imaging. That is, if you just get a neutral, you can see what looks like a cord that has room, but various movements can lead to compression that you may otherwise miss. We have started doing tensor imaging now, which is a way of assessing the flow of water through axons. And of course, they should be cranial to caudal. And if we start to see the tensor imaging and the water movement going out of plane, then one can deduce that there is in fact some axonal damage. And lastly, we'll do cineflow, where we will look at the CSF flow at the cranial cervical junction. I also wanted to show you this image. This is an image that may make you feel sort of good, nice sagittal image, but then when you look on this MRI from the exact same date here, you can see that the growth plates, the synchondroses on the right side of the foramen magnum have closed and have stopped growing, whereas the left appears to be remaining open. So even though your sagittal looks good, what you really have is a child who has no room on just one side of the cord. So you have to pay attention to your axials. When we look at the clarity data here, you can see that essentially the surgeries are done at a very young age, with the exception of this one birth cohort that's the oldest. And what we think happened there was an evolution again, a paradigm shift. This is the time when MRI started to become available. This was the time when foramen magnum stenosis was recognized as a cause of significant morbidity and mortality, and a lot of older people underwent this procedure. But this birth decade, you can see the mean age is right around 14 months, 1.2 years, with the median age being right around 10 or 11 months. The frequency between centers is actually fairly constant, right around this 20%, a little bit more frequent at Johns Hopkins, but we think that may have to do with some ascertainment bias that occurred back in the 80s and 90s. But pretty much we're looking at around 20% of children with achondroplasia identified using various testing strategies at various centers at around 20%. And here you can see that essentially by the time we get down to 2 years, almost everybody's been operated on, 3 years. When we looked more carefully at these older individuals, what we've seen primarily is that they are international adoptions. Not exclusively, but a lot of these are children that are brought to medical attention following adoption, and we're finding problems on their arrival. From an orthopedic perspective, the surgical burden really falls into two domains. One domain is the need for spine surgery, which we defined as C3 down, and extremity surgery. So I mentioned genu varum. Most people with achondroplasia have some degree. It's not always progressive and it's not always symptomatic. We're not completely sure why it happens. It may have to do with a fibula that's longer than a tibia, ligamentous laxity. People have postulated obesity and excess weight, and also asymmetrical growth of the proximal tibial physis, meaning the lateral side grows faster than the medial side. If the deformity is progressive, if we see thrusting, which is the lateral movement of the proximal fibular head during gait, knee pain, functional differences, then we think it is appropriate to treat this person. And everybody's a little bit different. We have to take into consideration the age of the patient, where in the leg the deformity is, and the number of levels. It could be as many as 3 growth plates that are involved, as well as internal tibial torsion. So here you can see a little bit that this patient really doesn't have it, but a lot of times when the kneecap and the patella is facing forward, the great toe can be off at an angle, and the tibia needs some derotation. Here you see examples of a procedure. This is osteotomies, primarily here at the proximal tibia, and the result a couple years later. More recently, we are starting to perform 8-plate procedures, and this is someone here you can see 1 year later. So this is a procedure that tethers growth on one side of the growth plate, allows growth on the other side, and over time it relies on linear growth to straighten the deformity. Spinal stenosis can be present really anywhere throughout the spine. Complaints can include neurogenic claudication, decreased endurance, back pain, persistent fatigue, numbness and tingling in bowel or bladder issues. Especially when it's in the lumbar region, it can be relieved by squatting or sitting, and that helps to pull the lordosis out and create more space. And anything that affects the general shape of the tunnel can predispose. So here you see an individual with thoracolumbar kyphosis, where right across this apex of the kyphosis is excessively narrow. MRIs and myelograms are used to find the level of the stenosis. Non-surgical treatment includes weight loss, core strengthening, and then depending upon what types of levels and how many, laminectomies with decompressions and sometimes fusions are performed. I want to touch really briefly on this biomarker section, and then I think Laura wanted to take a break. I think that would be a good time. But I think this information is going to be important to try and understand what new things are coming in terms of potential pharmacologic therapies. So C-natriuretic peptide is a small 17 amino acid peptide with this loop structure here. It belongs to the natriuretic peptide family, but it really doesn't have much of any natriuretic effects. It's primarily a paracrine signaling pathway inside the growth plate. Interestingly, its receptor is expressed very much in the same regions that the FGFR3 is expressed. And CNP's function in those areas is actually to drive growth. So where the FGFR3 signaling pathway slows growth, CNP signaling drives growth. It's encoded for by this NPPC gene. This gene makes this protein, which then to become active is cleaved into an entelopeptide and the bioactive form. So the bioactive form is subject to various types of clearance pathways, and therefore measuring the NT-pro levels is very much going to be a function of how much is produced. Both of these compounds are measurable in blood. Very good normal ranges have been established, and in fact, in typically growing people, the concentration of NT-pro and CNP correlate very well with linear growth velocities. So this bioactive CNP can signal through its receptor, which is NPRB, and that leads to the generation of cyclic GMP. It can also be bound to a dummy receptor, as well as to some membrane endopeptidases to help clear the CNP. So it's for these reasons measuring the NT-pro can be a more accurate reflection of production. So we set out to try and understand more about what CNP levels were in individuals with these FGFR3 family of conditions. And we had 63 kids with achondroplasia, adults, 20 and 6 children with hypochondroplasia. Obviously, they had short stature. And you can see that their z-scores, their standard deviations were in fact elevated for both CNP and NT-pro. The other thing is I mentioned that CNP signals through the NPRB? Well, there is a skeletal dysplasia that's caused by loss of function NPRB mutations. That's called acromesomelic dysplasia of Merito. And what we saw when we looked at CNP levels there and NT-pro levels there is they were very significantly elevated compared to baseline. Here you can see a reference range, achondroplasia and hypochondroplasia, as well as our AMDMs. And these are statistically significant across the different diagnoses. This is a plot of our NT-pro levels as a function of age in boys with achondroplasia. And you can see, while there are certainly some in the typical range, there are elevated levels. And what we recognized is that there is, in fact, CNP resistance in the growth plates of achondroplasia. This was known to cell biologists going back here all the way to 1999. But ordinarily, CNP signals through its receptor and inhibits its own synthesis. So the fact that if your receptor was absent and you had Merito, AMD Merito, or if you had an FGFR3 apathy, the fact that the CNP's levels were higher suggested that this signaling is not functioning typically. And what we ultimately learned is there's a crosstalk in these pathways, and this is how we have a general understanding is that FGF signals through the FGFR receptor, like we spoke about, and it leads to second messenger signaling. Here we can see that CNP signals through the NPRB receptor, leading to the generation of cyclic GMP. Well, as this signaling occurs, there's also crosstalk, and as P38 is generated, it actually goes and inhibits the downstream conversion of these second messengers. And the second messengers here in the achondroplasia FGFR3 pathway go and actually inhibit the generation of cyclic GMP. So a little complex, but I think a reasonable way to create an analogy is in terms of growth in the growth plate in these proliferative and hyperplastic zones. We have the CNP signaling through NPRB with a pro-growth pathway. It is a step on the gas. I'm going to grow faster. I'm going to drive faster pathway. And conversely, here we have FGF signaling through FGFR3. And this is a slow growth step on the brake pathway. But unlike a car where the gas and the brake are completely independent, these pathways talk to each other. So when you step on the brake, you actually partially inhibit the gas. And when you step on the gas, you actually partially inhibit the brake. And I think that's what is going on. This is certainly a simplification, but it is a key part to understand the proliferative and hypertrophic zones and how they function in achondroplasia if we're going to go on and talk about therapies, which in fact will be our next session. So that being said, I think, Dr. Tosi, if you want to take a little break here, we can do that, and then I can talk about this, or I can just go straight forward.
Let's take a very exciting adventure.
Not a lot more, but definitely a little bit more, because we are in a relatively exciting time, in that we have multiple drug companies and opportunities to try and get into this proliferative and hypertrophic zone and change the growth patterns. So we talked about, here's the same sort of cartoon that I just mentioned to you. Here is the NPRB and the green ball is CNP. So there is one drug that is a CNP analog. It's short acting. It's named vosoritide. It is a daily subcutaneous injection of a pharmaceutically altered CNP to increase its half-life, and it signals here, and essentially it's asking the biologic question, can I step on the gas hard enough to overcome the parking brake? And I will show you the data that says we can, at least in a small degree. And this drug was actually FDA approved for children with achondroplasia in the United States 5 and up back in November. A second drug being developed is a drug that's called Transcon Cnp. And this is essentially a time release version of CNP. It is well, we're still in dose finding trials, but the expectation is that this will turn into a once a week subcutaneous injection. The next drug that's being developed is essentially a soluble receptor. So remember, we talked about FGFs coming in and binding to the FGFR3. So the idea here is we're going to create a soluble receptor. It will bind FGFs and not allow FGFR3 signaling to continue. This is in dose finding trials, a subcutaneous injection. And lastly, there's a drug that is oral, where it's going to come in and specifically inhibit the tyrosine kinase domain of the FGFR3. And in that way, these two drugs are trying to inhibit the brake, and these two drugs are trying to step on the gas. This is the publication here in the Lancet from September of 2020 that talks about vosoritide as a once daily subcutaneous randomized double-blinded placebo-controlled trials. There was 121 people, 61 in placebo, 60 in vosoritide, and they looked at growth parameters and safety over a year. And essentially, the safety events are here in this white chart, and they really are injection site issues. Injection site reaction, injection site erythema, injection site swelling. These were the ones that had any sort of, excuse me, significant frequency. Because CNP does interact with the other natriuretic peptide receptors at a much less potent way, blood pressure was measured and there was not much difference identified. In terms of efficacy, what you can see is in terms of changes in growth, there was a 1.57 centimeter increase in growth velocity on an annualized basis that was statistically significant. The z-scores went up about a quarter of a standard deviation, and there was no significant change in body proportions. So what we know about children in this 5 and up age group is they really grow at 4 centimeters a year. They're very consistent growth velocities. Here you can see centimeters per year. There's our baseline of 4. This is where both groups started. The orange is placebo. So we both started at 4. 1 year later, the placebo group is still growing at 4. And this group, on average, here is growing at 5.5. So we're talking about an additional 1.5 centimeters of linear growth on average in an individual. Obviously, we needed to continue that trial. We needed to know what was going to happen in year 2. And this is a different type of grid, but each of these x-axes are 6-month intervals. Average growth velocity again on the y-axis. Here you can see both groups started at 4 centimeters a year. 4 centimeters a year, 6 months later. Here's our treatment arm. This is what I showed you on the last slide, and then here's the data from the second year. So placebo was switched to vosoritide, and the children on vosoritide stayed on vosoritide. And what you can see, excuse me, is the 1.5 centimeters seemed to persist in the second year. And when the patients switched from placebo to drug, they also had that additional 1.57. Now, I will call your attention to the error bars here. There's a lot of variation and a lot of overlap. So I think it's important. This is data that comes specifically from the supplemental. These are spaghetti plots of boys and girls that were in the treatment arm. So I know some of you are going to say, well, how did people start up here? They started up here because they had limb lengthening surgeries. And if you're looking at each of these lines and individuals, you'll see there's no question that there's a general upward trend in height and therefore height velocities, but there are very few people that are actually changing. They're a little bit taller on the achondroplasia scale is the way to put it. And I think, in my opinion, this drug has a modest effect and may be appropriate for some families, but I don't think it has to be prescribed for medical reasons. And then this is just a really quick summary to tell you where these other trials are. All this stuff comes from clinicaltrials.gov, but Accomplish is the time release version of the CNP. This is specifically for 2 to 10-year-olds. And here you can see there are going to be at least 4, if not 5 groups, 5 dosing cohorts with a 3-to-1 dose per placebo to try and find the right dose. They are looking at safety and tolerability as endpoints, as well as an annualized height velocity differences. Estimated primary completion date is sometime next year. This is phase 2. This is our oral tyrosine kinase inhibitor. Again, 2 to 10. Here you can see they're looking at a minimum of 4 escalating dose cohorts. And then once the dose is selected, there will be a dose expansion cohorts of an additional 20 patients. They're looking for treatment emergent adverse events, as well as changes in baseline and annualized height velocity. And the estimated completion date here is sometime earlier next year. And our last drug is the soluble FGFR SOP and 2 to 11 with a younger exploratory group. There's going to be 3 dosing groups with 54 kids selected into them, and as well as this small exploratory cohort under 2. Again, treatment emergent adverse events, as well as change in linear growth, with this expected to be completed around this time next year. So that really was all I had for everyone. Just to acknowledge our group here, acknowledge the Clarity group, Dr. Hoover Fong, Lagar, and Hecht, as well as my family. So thank you, and we can keep having some discussions.
Terrific.